I firstly got to say, this is so out of my comfort zone, but I'm going to make an effort to tell you in the next 20 to 25 minutes about therapeutics in NAFLD. So I've titled this, Are We Getting There? Because I think this is an evolving field that will change over the next couple of years. So in order to understand this, and if I can get this to move, mouse. So in order to understand this, we probably need to understand a little bit about the pathophysiology of NAFLD. And so, Marianne's done a wonderful job explaining all of this to us. So remember, non-alcoholic fatty liver disease is a wide range of conditions from simple steatosis to inflammation to fibrosis and cirrhosis. And that there are a number of potential consequences of this, including cardiovascular disease, B-cell failure and type 2 diabetes, and perhaps the thing that concerns us the most here in this room is the liver consequences, which is progressive fibrosis, cirrhosis, and hepatocellular carcinoma. Now, in order to kind of understand this, one needs to think about the subset of patients that are going to have the progressive disease. And so you can think about this as two separate phenomena. So the first phenomenon is those patients who have fat in the liver, but this is benign fat. In other words, it's fat that's doing nothing. And then a subset of those will have inflammation associated with that fat, and some of these will then progress to fibrosis and cirrhosis and consequences of that. We've seen this again as well. In order to understand the people that are going to get consequences as a result of non-alcoholic fatty liver disease are probably the people who have existing fibrosis. And so this is, and you've seen this data again in the previous talk, but this is two different studies looking at mortality associated with NAFLD. And you can see the mortality seems to be associated or predicted by patients who have fibrosis. And if you look down at the bottom, the vast majority of these people will actually die from cardiovascular disease and cancers rather than liver-related consequences. And so these are some of the other things that we will need to think about in terms of therapeutics for NAFLD. So when we think about therapeutics, we need to understand the mechanisms that drive the progression to fibrosis and end-stage liver disease. And this is perhaps the simplest way of explaining this. So this is a combination of metabolic abnormalities associated with apoptosis and inflammation that come together to give you liver fibrosis, which then progresses on to cirrhosis and hepatocellular carcinoma. And this makes the basis of therapeutics. In other words, if you can try and stop bits of this engine, you will then stop progression to end-stage liver disease. So in order to understand some of the data I'm going to show you in a couple of minutes, and there's loads of this data around, we need to understand what the appropriate endpoints for NAFLD therapeutics are. So the FDA have decided that for phase 3 studies, you need to have biopsy-proven NASH using the NAS score, and they think NAS score is greater than 2, together with fibrosis, are the kind of inclusion criteria for studies. The primary endpoint of these studies needs to be complete resolution of steatohepatitis and no worsening of fibrosis, or at least 1 point improvement in fibrosis score with no worsening of hepatitis. So in other words, inflammation and fibrosis, one reducing, the other remaining stable. However, the early phase trials are usually in populations at risk of progression, and the primary endpoints are really based on mechanisms of the drugs tested, and often with reduction in hepatic fat as assessed by non-invasive markers like MRI, proton density, fat fractions, or CAP. So let's go back to therapeutics and think about the 4 things that drive that engine. So this is metabolic abnormalities, inflammation and apoptosis, antifibrotics, and clearly the gut-liver axis as well. I don't want you to read this, but I just want you to look at the reference at the bottom. This is a really nice article, and so if anyone wants to go and read about therapeutics, I should go and have a look at this. So what works and what doesn't work? Suzanne asked about this earlier. Diet and exercise certainly works, but it needs at least a 10% loss in your body weight to get improvement in fibrosis. So this is often difficult, and it's often difficult to maintain for patients. Insulin sensitizing agents have worked, and certainly the glitazones have had some effect in terms of reducing hepatic fat and a little bit of inflammation, but they seem to be most effective in patients who've got existing type 2 diabetes or in the pre-diabetic state. Anti-lipids improve your lipid profiles but have very little effect on inflammation and fibrosis. And antioxidants, particularly vitamin E at high doses, does work, but there have been issues about risks of prostate cancer and other side effects of vitamin E. So what are the other upcoming agents in terms of metabolic targets? It's this one that's probably the furthest out at the moment. So this is obeticholic acid. It's a semi-synthetic bile acid analog that binds to the FXR receptor and has a lot of good anti-lipid and anti-inflammatory effects. So this is in phase 3 studies at the moment. This is a phase 2 trial, which was out to 72 weeks. It was a placebo-controlled study. And you can see on the bar graphs on the left, this is the primary endpoint that the FDA have said is important, which is fibrosis improvement and no worsening of steatohepatitis. And you can see it clearly did better than placebo. It also had some beneficial effects, at least in some of the lipid markers in peripheral blood. And if you look at fibrosis here, there was clear improvement in terms of your fibrosis regression out at 72 weeks, and this continued out to 96 weeks. So this has moved into phase 3 studies at the moment, and this is probably one of the most promising agents that we have in terms of NAFLD therapeutics. The other promising agent that is also coming into phase 3 trial now is this agent here called elafibranor. It's a dual PPAR alpha and delta agonist. PPAR alpha and delta are a nuclear nuclear receptor proteins that have anti-inflammatory effects and effects on lipid metabolism. So this was the phase 2 study, which was looking at elafibranor versus placebo out to 48 weeks. And as you can see, at least in terms of the primary endpoint, this had no effect, so it wasn't significant. But when they did a post-hoc analysis in those patients who had NAS scores greater than 4 on histology, there was a clear evidence of benefit of this particular agent. So this is moved out into phase 3 trials that are ongoing at the moment. The next group of drugs which are going to be interesting is this group. This is the Acetylcoacarboxylase inhibitors. This is an enzyme that's involved in de novo lipid synthesis. And so this is blockage of this enzyme with this particular drug called GS0976. An early study out to 12 weeks, so looking at endpoints that are not histological now, but that are markers of fibrosis and inflammation. So this is MRI-PDFF, looking at liver fat, and MR elastography, looking at liver stiffness. And as you can see on both those accounts, this drug for 12 weeks had some beneficial effect, both in terms of reducing fat in the liver and some effect in terms of liver fibrosis as assessed by MR elastography. So what about apoptosis and inflammation inhibitors? So this is the next group of drugs we need to think about. So this is a combination therapy with an apoptosis signal regulating kinase inhibitor called GS4997. This is combined with a monoclonal antibody called simtuzumab. Simtuzumab is a LOX-L2 inhibitor. LOX-L2 is an enzyme that's involved in sort of collagen modeling in the sort of fibrotic liver. And so these two drugs were combined together. And again, just to show you some data in terms of fibrosis improvement without NASH worsening, as you can see, combining these two actually had a beneficial effect. Simtuzumab was tried on its own prior to this and had very little effect in terms of fibrosis regression, and so now it's been combined with this particular agent. So we've seen this a little bit as well. So this is the effect of the chemokines in terms of promoting inflammation and fibrosis and lipid metabolism issues within the liver in terms of fat. And so this is the centaur study, which looked at Scentsyviroque, CCR5 and CCR2 inhibitor for 2 years with biopsies as the primary endpoint. And you can see it actually failed to show a beneficial effect on its primary endpoint. But if you looked at secondary endpoints in terms of improvement in fibrosis state, so they had much more of an antifibrotic effect than an anti-inflammatory effect. And so this is actually going out to a phase 3 trial in patients with advanced fibrosis and particularly looking at its antifibrotic effect. So final group of drugs one needs to think about is the antifibrotics, and I'm just going to discuss one. This is fibroblast growth factor 21. It's a non-mitogenic hormone but has a very short half-life and has very good effects both in terms of beneficial metabolic effects and an antifibrotic effect. And so BMS have pegylated this a bit like pegylated interferon alpha so that it increases its half-life. And this is an early phase 2 double-blind placebo-controlled trial that was presented recently at EASL just for 16 weeks to kind of see whether there was any beneficial effect. And as you can see in the next slide, it had effects both in terms of reducing your serum ProC3, which is a marker of fibrosis in the liver, and an absolute improvement in hepatic fat fraction as assessed by MRI-PDFF at week 16. And so if you think about the NAFLD pipeline, this is the sort of graph that we saw with hepatitis C perhaps about 7 or 8 years ago. There are more than 50 drugs in development for NAFLD that are coming through various stages of development. And in fact, the FDA has given some of these fast-track authority, and some of them have been given breakthrough designation because we realize that this is a big issue, at least in terms of therapeutics. And so for those of you that are thinking about investments, this is clearly an emerging market, and this is a review in Drug Discovery of Nature, looking at the market for these drugs in 2025. It's probably worth $15 billion, so go and invest in the companies now. But I'm going to stop there and say that there are going to be lots of new drugs for NAFLD coming through, but what is going to underpin all of this is a need for a better understanding of the pathophysiology that drives the machinery to end-stage liver disease. We really need some biomarker development for prediction of progression, inflammation, and fibrosis, and perhaps need biomarkers as a response to therapy. And clearly, there's going to be improving imaging and sonographic modalities that are going to be helpful in the future. So I'm going to stop there and thank a lot of people who've lent me slides and that I've had discussions with. And hopefully, if there are any difficult questions, I'll take them now. Thank you.